evening and a very warm welcome to everyone. I'm Neetu Abraham, Community Manager at MediSage e-learning, a platform made by the doctors for the doctors to foster continuous knowledge sharing, meaningful learning and professional collaboration. On behalf of MediSage, I'm delighted to welcome you all to GOGS ABHYAS webinar series. On the occasion of World Cancer Day, we are doing a cancer awareness program on the topic Gynecological Cancers, Current Perspectives and Emerging Advances. Now, I would like to invite the convener and MOC of today's webinar, Dr. Shama Sultana. Ma'am is a very enthusiastic and cheerful gynecologist and infertility consultant. She is the chairwoman and a chief gynecologist at Hopewin Hospital. She is also the South Zone coordinator at SHSTI Committee Foxy and also the scientific team member of GOGS. I now invite ma'am to carry forward this session. Over to you, ma'am.
Yeah, thank you, Neetu. So I welcome you all for this session. As Neetu have explained that this is a World Cancer Day initiative and this is a GOGS ABHYAS webinar series of GOGS, and this is Cancer Awareness Program on the topic Gynecological Cancers, Current Perspectives and Emerging Advances. World Cancer Day reminds us of the importance of awareness, early detection and evidence-based care in reducing the burden of cancer, especially among women. Through this academic initiative, GOGS ABHYAS aims to promote meaningful learning and updated clinical insights to improve outcomes of women's health. We are honored to have distinguished guests and speakers, experts with us today, and we thank all the participants for joining this important program. And I'm truly honored to invite our chief guest of today. It is a great privilege to introduce Dr. Mala Sibal ma'am, a distinguished consultant, gynecologist, and an internationally renowned expert in gynecological ultrasound, fetal medicine, and ovarian tumor diagnostics. Dr. Mala Sibal ma'am serves as consultant gynecologist, Department of Fetal Medicine and OBG ultrasound at Manipal Hospital, Bengaluru, and has made outstanding contributions to the field of obstetrics and gynecology. She is a board member of ISUOG, an active member of its scientific committee, and an international faculty member of ISUOG. She also serves as an IOTA, that is International Ovarian Tumor Analysis Ambassador, and has conducted numerous IOTA certification programs, overall 27 worldwide, playing a pivotal role in advancing standardized ovarian tumor assessment. She is author of the acclaimed book Ultrasound in Gynecology, an Atlas and Guide, published by Springer, which has been widely assessed by clinicians across the globe. Dr. Sibal ma'am has published extensively in reputed international journals and has delivered over 500 invited lectures across 24 countries, sharing her expertise at national and international conferences. On a personal note, I deeply and humbly inspired by her extensive work with the International Ovarian Tumor Analysis, that is IOTA program. Her clarity, scientific rigor, and practical approach have significantly enhanced our understanding of ovarian tumor evaluation. So we're truly honored to have you, ma'am, here with us today, and we look forward to an enlightening insights from you, ma'am, for this session as a chief guest. Over to you, ma'am.
Thank you very much. At the outset, I'd like to thank all of you for this invitation. I'm really honored. I just want to make a big disclaimer here that though I'm a gynecologist, I have been doing focused ultrasound work for the last 23 years. So my knowledge is almost focused in the field of ultrasound, and I'm not very good with the rest of gynecology or gynec-oncology. I am definitely passionate about gynec-oncology because a lady's life is really not just herself, but I think the entire family often rests on her existence and her health. And so I think, helping a lady is helping the entire family and finally helping the society at large. So I think when it comes to malignancies, gynecological malignancies, they do cause a lot of morbidity and mortality in our women today. And though treatment has advanced, I think we are still not reached where we could with diagnosis of these diseases. And I think that's where any improvement will make a change in the outcomes for these women. And diagnosis would include screening, awareness, and ultrasound. So, the awareness, of course, I think a lot of the institutions are nowadays trying their best to increase awareness through various programs. Screening, we are still lagging behind, and that's why cancer cervix takes a huge number of our patients, and I'm sure you all are covering that. And the next is ultrasound. Now, ultrasound, in my view, has a huge role to play because it is the primary modality of evaluating the female pelvis world over. And when it comes to ultrasound, I think we can contribute by making an early diagnosis and an accurate diagnosis, at least to say likely malignant or not malignant. I think that itself is huge. And the advantage of early detection is, the outcomes are better. The If we make a right diagnosis, we can refer this patient to the right doctor, because many a times we have patients who come in who, for example, a few days back, I had a granulosa cell tumor patient, just a general gynecologist. She just removed it and just let that patient be. There was no follow up, nothing. When she came to me, she had metastasis all over, with multiple metastasis. So unless it is managed by an oncologist who knows what is the follow up, what are the tumor markers, unless we counsel our patients, and I think many of us doctors are so busy that we don't have time to counsel the patients. We just manage them and tell them, you can go ahead, all is well. But unless we sit down, we spend time with them, there's a possibility that they are not aware of the significance of the disease they have. So that is one thing. Now, when it comes to ultrasound, really there are two parts to ultrasound. One is to see what the features that are there on ultrasound. And today we have amazing machines, amazing technology. We can see a lot. But very often we get reports where the final impression in the report is complex mass correlate clinically. And then there'll be another one which says complex mass suggest MRI. The MRI will also say this is the mass, these are the features, these are the septate, this is the color score, suggest CA125. So this patient goes round and round because we are seeing what is required, but we don't know what that means. And to understand what that means, for example, in ovarian masses, where ultrasound is a huge role to play, if we are able to interpret what that means, which we can do either subjectively using our pattern recognition. Pattern recognition is like when I have seen one dysgerminoma, second dysgerminoma, four dysgerminomas, when I see the fifth dysgerminoma, it brings back memories of my previous cases that I've seen, and I say, oh, this looks like a dysgerminoma. That is pattern recognition. And subjective pattern recognition is fantastic in the hands of an expert, but it takes some time and effort to become an expert. The other way to do is objective evaluation. And objective evaluation can be done even by beginners, because now with the IOTA group, for example, has various models which can be used to say this is likely malignant, this is a high risk for malignancy, and this patient can then be referred to an oncologist, ensuring the best possible outcomes instead of a regular gynecologist who's not experienced in gynec oncology managing this patient. So that is the importance of proper interpretation. And I think the sad part is that even today, very few people have a thirst for knowledge. Once we are done with our post graduation and we can earn our income, there are very few who are driven to academics. And academics is not because it is hi fi or it sounds cool or because I can tell people I can talk at conferences. It is because you should be able to deliver to your patient when they come to you with trust. So we must all treat our patients as if what we would have done for our mothers or our sisters or our family members. That's the attitude we should have. If we think we cannot see or we don't know, we can read, we can ask. There are so many places that we can go to help, and that's how it should be. And there are lots of possible ways of learning. There are multiple articles today. You pick up any topic. I was just reading parametrial endometriosis yesterday. There are 40 to 50 articles in the last 2 years. So the knowledge out there is huge, and I think all of us have to make a commitment into learning something every day so that we keep updated and provide the best to our patients. When it comes to advancement in technology, I'm sure all of you are going to discuss the various aspects that are available today. You have these markers, DNA markers in your blood, and there are, numerous other technologies, nanotechnology, all that. But when it comes to ultrasound, there are two advances presently, and one is radiomics. Radiomics, what it does is it helps us see features within a mass that may not be seen with a naked eye. And the second is the use of AI, particularly if you want to see whether this is cervical cancer, whether this is a sarcoma or it's a fibroid. The human eye has some limitations. We may be able to say likely malignant, likely sarcoma, but the advantage of AI and other modalities is that we can actually predict this with much higher accuracy. So that's where I think ultrasound is advancing into. So another thing that ultrasound can often help us is with guided biopsy. For example, we have a placental site trophoblastic tumor. You don't want this patient. So what we do is under ultrasound guidance, we are able to do true cut biopsies for sarcomas, for placental site trophoblastic tumors through the cervix. So I think that is another role that ultrasound has to help us with guided biopsy. We do a lot of guided biopsies for malignancies, for metastatic recurrences, for cervical malignancies that are a little deeper inside, not the exophytic ones, but the deeper ones. We do it for placental site trophoblastic tumors, for sarcomas, etc. So I think that's another place where ultrasound has a role. And, we really can contribute a lot provided our commitment is there to do the best for our patients. So with this is all I have to contribute, but my stories that are numerous. I just want to tell you I lost a cousin to a malignancy because a dystia was misinterpreted as an endometriotic cyst because it wasn't very heterogeneous. She left her 8-year-old child who grew up without her. And I think it is very sad that on ultrasound it was misinterpreted, and when they went back, it was highly advanced. So this child has grown up without a mother because of somebody's casual ultrasound scan with no use of Doppler. So I think all of us, there are so many cases. I had another patient, I don't know if some of you all have. I'll just give you this one last example of a lady who came to us with actually huge mass in the abdomen and pelvis with multiple cystic locules within. It looked really odd because the locules looked like they were stuck to each other. And while doing a scan, this patient, while she gave me a history, she had her husband had multiple aneurysms in his head. So he came with a stick. He already had a stroke and he was told he won't live long. They had an 8-year-old and a 12-year-old child. And she had constipation for the last 1.5 years. She went from one hospital to the other hospital. They did a lateral sphincterectomy. I don't know what that was for, to say, because they said your anal sphincter is too tight to relieve her of her constipation. It didn't improve. Then they said she's depressed because the husband is not well. So every meal, the husband would sit with the folded hands. Please eat. We have 2 children. You must live for them. But by the time I came, she had multiple mets from a colorectal cancer, and I could see the entire colon on transvaginal scan was thick, and I suspected a colorectal, though I'm not a person. I do only gynecology, but it was finally a colorectal cancer with advanced mets, and I don't know if those children have parents at all today. So I feel really sad that when a patient comes to us with trust, I think we have to somehow live up to it, whether it is studying, whether it is taking a second opinion, whatever it is. Cancer can take the life of a lady. And for that family, that lady is probably means the world. For us, it is one of our many patients, but for that family, it is their world. So with this, I leave you all to go ahead with the rest of it. My contribution was to the level of ultrasound, but I know ultrasound is commonly used, can definitely help pick up these cases early and make an appropriate diagnosis so they are referred to the right patient, right doctor, and the right tumor markers are sent and they're investigated properly. So that's it from me. All the very best to you all, and I'm really happy that you all are putting in so much efforts to increasing awareness, all of you. God bless you all. You all are much younger than me, and I wish you all the very best.
Thank you. Thank you so much, ma'am. Thanks for joining, ma'am.
Bye.
And bye, ma'am. I request Dr. Anita, ma'am, to continue the session and introduce our guest of honors.
Very good evening to one and all, respected seniors, and to all the stalwarts. It's a proud privilege and an honor for me today to be introducing our guest of honor today. And before that, I would like to welcome all the participants, the speakers, the guest of honors, our GOGS Secretary, Truma Shankar, and Madam. And thank you, Shama, for being beginning, you start the spark to start of all this academic activities. So I would not take much of your time. I would like to introduce Dr. Kandula Ramu. Sir is a consultant medical oncologist with over a vast experience of 12 plus years, whose expertise in solid tumors and hematological malignancies, with a strong background in academic medicine and multidisciplinary cancer care. He is currently the consultant medical oncologist at KIMS Chakra Cancer Center, Guntur. And sir, over the past 12 years, has vast experience and has worked over various hospitals, oncological hospitals in Guntur and Vijayawada, and associated even with the Katuri Medical College previously. He has various academic feathers in his cap with multiple publications in journals of clinical oncology, oral and poster presentations at ESMO Asia, ICON, Hematocon, SARC, and SIR's main areas of expertise are in chemotherapy, targeted therapy, and immunotherapy. Ramu sir, welcome to the session. Could you please share some insights from your side?
Yes, madam. Thank you. Thank you for introducing me, madam. Good evening, one and all. Good evening to my seniors and my dear colleagues for giving me the opportunity. Gynecological cancers continue to be a major health concern, especially in low middle income countries. Late diagnosis and unequal access to care still cost lives. The three most common cancers we deal with are cervical, ovarian, and endometrial cancers. Each tells a different story. Cervical cancer is largely preventable, yet it remains common because screening and HPV vaccination are still inadequate. This is a missed opportunity. Ovarian cancer has the highest mortality mainly because it stays silent and is diagnosed late. By the time the symptoms appear, the disease is often advanced. Endometrial cancer is increasing, driven by rising obesity and metabolic disorders. Recognizing these trends is the key to detect earlier, treat smarter, and improve outcomes. And improve outcomes for our patients. Endometrial cancer is increasing today mainly due to obesity and lifestyle changes. Treatment has become more personalized with the biomarker testing. New therapies like immunotherapy, targeted therapy, and drugs, targeted drugs are improving the outcomes. Surgery and radiotherapy are now more precise, but the real game changer is prevention and early detection through HPV vaccination and regular screening. With this, I am going to finish my introduction to this gynecological malignancies. Thank you, madam. Thank you.
Can I have the next slide to introduce Dr. Shrikant sir?
Anita, ma'am, you're muted.
Sorry. Yeah, I'm sorry. It's my proud privilege to introduce Dr. Shrikant Boga sir also. Sir, welcome to the session. Sir is a senior consultant medical oncologist from Omega Hospitals, Guntur, Andhra Pradesh. Sir is another senior consultant with 10 plus years of experience in medical oncology with special areas of interest in pediatric hemato-oncology and immunotherapy. Has extensive experience in solid tumors and hematological malignancies. His academic and research highlights are vast. He has recently done the Dana-Farber breast cancer preceptorship, has an Harvard executive education on advanced oncology management recently, and has various multiple publications and presentations at various national and international conferences. And Sir is an eminent speaker and faculty at the national and international in various platforms like on immunotherapy, breast cancers, lung, GIGU, and gynecological cancers. He's been a faculty for programs conducted by the major pharmaceutical companies and research centers like Roche, BMS, MSD. And Sir has various professional memberships. Sir would like your insights on this today's session regarding the cancer awareness, especially as gynecologists. We are the first ones who see the women, and then how do we go about in identifying and how should we have a match between the surgical oncologist and the medical oncologist, and how can we do a better for the women today?
Yes, and thank you for having me here. And first of all, I would like to thank everyone and Dr. Shama Sultana ma'am for giving this opportunity, and respected senior gynecologists and colleagues. And this is the kind of event, this is the academic event which are regularly doing for the benefit of the our for the learning experience and all these things. And if you look at the current perspectives and emerging advances in gynecological malignancies, there is a rapid development is in the form of of molecular oncology. So there is if you look at the previously what we are doing is there is a site specific treatment, like we are treating based on the ovary, cervix, and endometrium, but not in the nowadays, but not like this. So we are going with the tumor biology based treatment we are going with. And if you look at the BRCA status, that is we are regularly checking the BRCA status for ovarian malignancies, endometrial malignancies, and cervical malignancies, and breast malignancies. And so we need to check for the BRCA and HRD testing. We need to look for the MMR testing, that is mismatch repair deficiencies, and HER2 expression status. But if you look at the only what we are regularly observing is HER2 is becoming positive in breast. But if you look at the endometrium, ovary, and everything, and what we are regularly doing is HER2 test. We are regularly doing PDL1 test, and then other immune markers for what we are regularly doing is nowadays, because of development of robust molecular oncology, and we are in an era of precision oncology rather than grass, like when we are treating previously, that is already which we told is site-based, from the site-based treatment to biology-based treatment. Coming to the different malignancies, and what we are regularly observing is, when we are definitely gynecologists are of course heart of the diagnosing the disease. And why? Because there is a early suspicion and proper surgeries, proper staging, proper workups, and the referral pathways. These are the starting begins with you only. And if you give the best treatment to the patients, definitely this is the multi-tumor decision, and multidisciplinary management in the form of gynec surgeons and radiation oncologists, medical oncologists, and surgical oncologists, radiologists, pathologists, and even molecular labs also, which we need to together work as a one unit. So these are the things which comes into the picture. And when it comes to the if you look at the based on the individual malignancy, so previously in the advanced ovarian malignancies, and there is no treatment after the chemotherapy. But nowadays what we are regularly doing is HRD testing and BRCA testing. So those who are mutated for the BRCA, those who are positive for HRD, we have options of PARP inhibitors as a maintenance therapy. If you give the PARP inhibitors, that is olaparib or rucaparib, and it gives the improved progression-free survival rates, but in some cases and in some selected groups, there is a overall survival benefit is also there. And there are latest advances in terms of antibody drug conjugates in the ovarian malignancies, particularly those who are platinum resistant diseases. Coming to the endometrial malignancy, definitely this is one of the most immunogenic malignancy. And particularly in this malignancy, what we are regularly doing is MSI testing. So those who are deficient MMR or proficient MMR, we need to look for that. And those who are deficient MMR endometrial malignancies, and if you give the immunotherapy, that is immune checkpoint inhibitor, the response rates is very high, and the disease control rates also very, very high. And these are the different developments. And moreover, if you look at the even, and when endometrial malignancy is stage 1A, previously there is no treatment for 1A. But nowadays, what we are regularly doing is molecular testing. if you do the molecular testing, we need to categorize whether it is the low risk or high risk or intermediate high risk or intermediate low risk. Based on that, we are doing the treatment. Even for sometimes those who are high risk stage 1A group, we are giving the full-fledged treatment in the form of radiotherapy and chemotherapy. These are the different advances which which were developed. And if you look at the cervical malignancies, those who are locally advanced cervical malignancy, only we have an option of concurrent chemoradiotherapy previously, but nowadays what we are regularly doing is immunotherapy. If you add the immunotherapy in the form of pembrolizumab to the radiation during the time of radiation, it gives the better event-free survival rates. That leads to it decreases the recurrence rates and it gives the overall survival rates. So immunotherapy has a role even in the neoadjuvant setting and metastatic setting in the cervical malignancies. So in the future, what we are regularly, the precision oncology is comes into the picture in the form of in the form of BRCA mutations and HRD testing and MSI testing and HER2 positivity. So with this, we have a more targeted therapies, that is ADCs, that is antibody drug conjugates, and more immunotherapy options which we are having nowadays. And moreover, we are having the personalized therapy. So when the mutation is detected, we are having a personalized therapy, and which subsequently which gives the better progression-free survivals and overall survivals that improves the quality of life also. So with this, I conclude, and it is nowadays what we are doing is we are living in one of the most exciting part of development as a molecular oncology, and particularly in the gynec malignancies, and there is a lot of development is there, and even the immunotherapy and everything is moving into the upfront setting in the form of neoadjuvant therapy and adjuvant therapies also. So moreover, these treatments are biomarker driven treatment rather than site-based treatment nowadays. And again, I would like to thank once again for the organizing committee for this academic event. Thank you. Thank you, ma'am.
Yeah, thank you, Ramu sir and Shrikant sir. First of all, for accepting our invitation and being the guest of honors for the session, and really valuable insights from both your end, especially about molecular oncology, which is actually a newer thing. Because what we think is once we take it out and then we know about this receptor testing and all, but you have really given us valuable insights on it. Thank you so much, sir.
Thank you. Thank you, Anita ma'am. And now we proceed for our session. The topic, gynecological cancers and current perspectives and emerging advances. We have a chairpersons, Dr. S. Umashankar sir and Dr. Vemu Aruna ma'am. Due to some technical issues, we are lagging behind. So I want to join in with Dr. Durga ma'am. Are you there, ma'am? On behalf of Aruna ma'am, Durga ma'am, can you join us as a chairperson? Okay, so let's go ahead with the introduction of our speaker, Dr. Mahati ma'am. Yes, Dr. T. Mahati ma'am. She's a consultant medical oncologist. She's a trained medical oncologist with strong foundation in solid tumors and hematological malignancies and experience across corporate tertiary care centers and academic institutions. Special focus on evidence-based and personalized cancer care in Tier 2 settings, and academic and research highlights like DNP thesis on histopathological response in breast cancer patients receiving NACT. And MD thesis is on inflammatory biomarkers predicting outcomes in ARDS, and publications in Indian Journal of Critical Care Medicine, and posters and presentations in APCC GI Cancer Meets. And she's a winner of AMOI Debate 2020. Her clinical interests are breast, lung, and GI malignancies, immunotherapy, CDK4 and 6 inhibitors, PI3K inhibitors, and targeted therapy in NSCLC and auto-ASCT myelomine lymphoma. So her approach to cancer care is comprehensive evaluation and biomarker-driven decisions and multidisciplinary, multimodality and treatment planning. So we welcome to the session, ma'am. Over to you, ma'am.
Thank you, ma'am. I'll share my screen. Yes.
Yes.
Thank you for the introduction, ma'am. So today I'm going to talk about a few updates in gynecological cancers. I think Dr. Srikanth has covered most of the topics that I would like to speak on. But anyway, first and foremost, our focus on gynecological cancers, we will be focusing on ovary, cervix, and uterine cancers majorly. So at the outset, I would like to talk about thing is like we most often focus on therapy part of the cancers management. I mean diagnosis and therapy part. But I think the first thing we should start focusing on is actually on preventive aspects and the screening aspects of cancer. So just to show you, this is our recent Globocon data, which was presented in 2022. Previously, cervix uterus has to be, I mean, the number one most common cancer. Now it is the second most common cancer in females. And the other thing is like right now we are seeing earlier onset of cancers, whether it be the breast, cervix, uterine, or ovary. Previously, it used to be in fifth or sixth decades, and now the breast cancer commonly it has come to second half of the third decade and in 40s also. And cervical cancer also we are seeing in younger generations. And even uterine cancers we are seeing in earlier, and that too, most of the uterine cancers, even early stage 1A and 2 also, we are actually seeing them to be pretty aggressive in that sense. So we are seeing a shift of the cancers, especially in mid and lower income countries, to earlier onset. The reason is not exactly known. So this is the same Globocon data in females. So breast cancer, we are seeing it is almost 26.6% in females, and cervix is 17%, and ovary cancers and uterine cancers come to about 6 to 7% each. So let us talk about first strategy for prevention and screening for cervical cancer. I think this is where we still have a lot of focus to be done. So the 2030 control targets are 90, 70, 90. This is what we are following now. So 90% of the girls to be vaccinated with HPV vaccine by the age of 15 years. And 70% of the women we should be targeted to be screened with high precision test at 35 and 45 years of age. And 90% of women identified with cervical disease should be able to receive treatment and care. So these are the targets for the 2030. So let's just have a look at why cervical cancer may be a success story. In fact, I was looking at the data compared to the Europe and the Indian data. We have a lots to do with catch up. Europe has got a very good data of cervical cancer screening and prevention being a success story. So they have brought down almost the incidence of cervical cancer by nearly 85% in Nordic countries, especially. So even the other European countries' data is also very good. So we have a lot to do in that area. Coming to cervical cancer screening, I think most of us, what we are practicing is actually pap smear testing or VIA also. But the latest what is going to come up is AI in cervical cancer testing. Most often it is going to be clubbed with VIA. So we have a small camera where we can put in we do the usual VIA, take the AI camera which has got AI, this thing attached to it. So what it does is it increases accuracy, reduces subjectivity, and yeah, obviously going on it will improve accessibility. So with this particular AI interventions with VIA, or even for the pap smear testing also, the slides can be read by AI. So this is going to reduce subjectivity more than anything, and also accuracy also. That is one step where it is going to come out in the next 5 years or a decade or so, which is going to increase our accuracy in cervical screening. So the next step in cervical cervical cancer prevention is HPV vaccination. We are also lagging behind in that. Probably right now, overall, the gender neutral vaccination ratio is still 50 to 60%. I think it is far less in Indian subcontinent. So I was looking at the newer data. I think this is already known for everyone. So if this effectiveness of quadrivalent HPV vaccine against SIM2 by age and doses, which is plot. So here we see that the patients who were vaccinated, I mean, so children who were vaccinated at 10 to 14 years, you can see the incidence rates and You can compare it with the women who were vaccinated at the age of 21 to 35 years and look at the incidence rates. So the maximum protection is when they were vaccinated less than 14, which we already know, but beyond 21 doesn't look that great. So our target has to be to vaccinate as early as possible. And 9 to 15 is the ideal and the golden age group. And now we have ideally the schedule is we all know 9 to 14 it is 2 doses, and beyond 14-15 years it is actually 3 doses. But most of the EU has adapted the single dose schedule in their vaccination schedules. So this is the data for all the countries which have adopted as a single dose schedule, especially for 9 to 14 years. And even up to 26 years also, most of them have adopted a single dose schedule. And there are few countries like Netherlands which are doing 2 dose schedules. So I don't know how many of you have, ma'am. I would be very happy to know how many of you are going to or adapting actually the 2 dose schedule. Right now, I'm doing more than 15 years. I'm doing following a 3 dose schedule. So I don't know how it is being from your side. So maybe with this data, I think we can safely adopt a 2 dose schedule even for more than 15 years also. So what we can target is to increase gender neutral HPV vaccination in adolescents. So right now we are most often targeting only in females, but I think we should also encourage and educate about HPV vaccination in male childs also. So 9 to 15 years. And we should also target high quality cervical screening, combining with methods like AI and all. And yeah, we should always opt for catch up vaccination. And yeah, effectiveness of HPV vaccination by age and dose and into we also know that, but we should also take in account the different washout periods. Okay, we have had a look at both the screening and prevention. So let me talk about early CS cervix and what is new in it. See, most of the treatments nowadays, it is not just about histopathology and about stage. Now we are looking at the molecular biology of each and every cancer. And how it is going to affect the treatment is we are trying to de-escalate treatment in diseases which which have good biology, and which are not good biology, we are planning to escalate the therapy. So this is a new data in early stage 1A and 1B. So we know it usually most of the patients, they do very well. So in such stages, we are trying to de-escalate therapies. How we are going to do it? So here we have new data which has come up, which shows that you need not go for an extensive pelvic lymphadenopathy, and sentinel lymph node biopsy is well enough. So if you do sentinel lymph node biopsy and it is negative, we can skip the pelvic lymphadenectomy. So stage 3, coming to stage 3 cervix, stage 3 is bad, which has got high chances of recurrence. So here we have data for 2 trials now coming up. Initially, the traditional teaching is stage 2 and stage 3. The main therapy is radiation. But even with radiation and concurrent just chemotherapy, the recurrence chances of cervix in stage 3 is pretty high. So we have role of immunotherapy coming up in stage 3 itself. So by that, we are almost doubling, more than tripling the PFS in some settings. So in stage 3, we have pembrolizumab, which we are now starting along with immunotherapy, along with radiation, and also beyond radiation also, and as giving in the neoadjuvant setting also. So this is where it is going to help us in decreasing the recurrence rates. And we have an interlaced style, which is also chemotherapy, which we are giving upfront, even above this, before the start of the radiation. We are having patients with small para-aortic lymph nodes now, stage 3, and or bulky inguinal or iliac lymph nodes. For those patients, instead of going ahead with upfront radiation, we are starting with neoadjuvant chemotherapy. So thereby decreasing the burden of disease. So this is also going to increase progression-free survival of the patient. So this is the latest in it. And stage 4 advanced CA cervix, I think as Dr. Srikanth has already pointed out, the treatment of CS cervix stage 4 is moving from chemotherapy alone to both immunotherapy and targeted therapy. So we have the role of immunotherapy, pembrolizumab, and along with targeted therapy, bevacizumab, which has come up in a big way. So that has improved the survival of patients from more than 6 months to 1 year in our setting. Coming to uterine cancers, uterine cancers now, as I said, it's all about escalation and de-escalation of treatment. So the first step to that is to actually do appropriate staging for a patient of uterine cancer. So any patient, if you want to either escalate or de-escalate, appropriate staging with the help of appropriate pre-treatment evaluation is a must. So ideally for both cervix or uterus, or for that matter, any gynecological cancer patients, an imaging of the abdomen and pelvis is ideal with either MRI or CT scan. PET is optional. That's what I would like to say. Unless and until you have huge para-aortic lymph nodes or considering the patient to be metastatic because of the other findings. Otherwise, good MRI, abdomen and pelvis and a CECT would be good enough to do appropriate pre-treatment staging for these patients. So once we talk about appropriate staging, why it is important, most of the times in cervix, in comparison with uterus, in cervix, we try to understage them because cervix is relatively good in that sense, the outcomes. But uterine staging, most often it's better to be on the other side. Because uterine cancers, even in stage 2 or stage 3, most often now there are higher chances of recurrences. So here we see, though nearly 50% of high-risk patients, they do recur. I'm talking about stage 2 and stage 3 patients. So, and 50% of lymph nodal metastasis are detected in endometrial cancer patients who are also considered as intermediate risk. So we have already, I think every one of us is aware that FIGO has come up with a newer staging in endometrial cancer. So here, not just histopathology and radiological staging, but this FIGO staging incorporates actually the molecular classification. So for each and every uterine cancer patients, we are doing molecular classification. It is a simple test which we sent on the biopsy. I think I have a slide for that. Oh, sorry, I missed it. So this molecular classification is a pretty simple test which we are sending on the uterine tissue. The turnaround time is around 2 weeks. It can be done by either IHC or complete NGS panel. It gives us information on 4 parameters. That is, we divide these by 4 molecular subclasses: the pole mutation, the MSI mutation, P53. So by that, we might mention them as copy number low or copy number high. So these are the 4 molecular subclasses. So with these 4 molecular subclasses, they are integrated into the actual FIGO staging now. So right now, if I want to classify or stage any endometrial cancer patients, so this is the newer molecular classification which is incorporated into the FIGO staging. So here we have downgraded some patients and we have upgraded some patients. So if we can see pole mutation, which is actually a very good subclass. So stage 2 pole mutation is a low risk. So in the same way, if you look at stage 1B and 1A, MMR and NSMP, they have actually been in the intermediate stage. So here we have upgraded them or escalated the stage. And with the pole mutation, we have de-escalated the stage because it is a very good molecular marker in that sense. So P53 is a poor prognostic factor. So any P53, most we have upgraded. Even stage 1A P53 is also intermediate risk. So where we have escalated the therapies. So I just wanted to point out the PORTEC data. So here we can see the outcomes in these patients, just rounded off 1. So TP53, we can see the recurrence for survival is pretty less when compared to pole mutation, which has excellent recurrence-free survival. So all these 3, pole followed by MMR and NSMP is intermediate and TP53 is the worst of all the subgroups. So this is how the treatment in adjuvant setting is going to be down the line in the future. Practically, we are now following it. Any P53 abnormality, even in stage 1A, we are actually going ahead with both chemotherapy and radiotherapy in those patients. Whereas in pole mutation, we are actually pointing out for observation even in stage 1 and stage 2 patients also. So this is how the molecular classification is going to impact the therapist down the line. And as I've already had a look at adjuvant therapies in metastatic settings in uterine cancer, now we have shifted from just chemotherapy alone to targeted therapies like trastuzumab and immunotherapies like pembrolizumab and lenvatinib. And we have other options like dostarlimab, which has also come up and it is pretty much available. So these are all there to increase the progression-free survival almost by more than doubling. So let me get to the last, which is the ovarian cancer. In ovarian cancer, I think most of us have heard about BRCA mutation and HRD testing. These have been practice changing for us. Surgical wise, I'm not the right person to comment, but yes, laparoscopic staging surgeries are pretty much being routinely performed. But as the trials and as the outcomes have stated, it is actually the volume which matters when we are doing or opting for laparoscopic staging surgeries in ovarian cancer. So the outcomes are comparable to open cases only in high volume centers. So all said and done, practically most often it is the open laparotomies which would be preferred unless and until it is in pretty much a trial basis or in high volume centers where laparoscopy has given almost about comparative outcomes for the CRS. And HIPEC also, I wouldn't go into that. So let me focus more on BRCA and HRD. BRCA and HRD is what we are doing routinely for most of our ovarian cancer patients. It is also pretty much acceptable financially also right now. So nearly 50% of ovarian cancer patients are going to be HRD positive, and around 20% of patients of them are going to be BRCA mutated. So either BRCA mutated or HRD positive patients, both of them are going to have an option of PARP inhibitor as one of their therapies. So how does a PARP inhibitor actually help? With when you look at the stage 3 ovarian cancer patients, most often their overall survival used to be around 2 years, 2 to 3 years. But only with the advent of HIPEC and also the PARP inhibitor, especially the PARP inhibitors, the average overall survival for stage 3 ovarian cancer patients has crossed 5 years. I think that is one of the success stories in that sense. So these are the pivotal trials and regulatory milestones for first line maintenance therapy in advanced ovarian cancer. So right now, if I'm having ovarian cancer patients, we all know most of the ovary cancers, 80% are diagnosed in stage 3. So most of them would be, if at all they are either HRD positive or even BRCA, they would be open for PARP inhibitors, which is niraparib or olaparib plus bev combination. Here we have almost survival rates of PFS rates of beyond 30 months for either of these trials, and overall survival is beyond 5 years in that sense. So we have all the options like niraparib, olaparib, and rucaparib, all are available in India, and we now also have generics, which makes it pretty much accessible to less than 20,000 per month for the patients. So this is how the treatment is overall. If I have a time, so initially we are opting for debulking surgery, or if it is stage 3 with bulky disease, we are actually planning for neoadjuvant chemotherapy, followed by debulking surgery, followed by either
Anita, any questions are there in the chat box? Still, yeah, Melty ma'am has to join.
Yeah, Mahati ma'am has joined, ma'am. She has joined
Yes.
just now.
If any questions are there, please let us know in the chat box.
Sure, sure, ma'am, sure.
Okay. Yeah.
So there's some issue with my this one, so I'm not able to share the screen. So I think I've almost come to the end of my talk.
Okay.
Yeah. I was just going through the final therapies for ovarian cancer. These are the three major malignancies which I was wanted to focus on. Yeah. So, if possible, I would like to know about your opinion on especially the HPV vaccination. It would be very nice.
Yes, ma'am. At present, HPV vaccination, we are giving to 9 to 14 two doses, and above 14, we are giving three doses.
Okay. Okay. Okay.
9 to 14, 0 in 6 months. Above 14, 0, 2, and 6 months.
Actually, Dr. Mahati,
Yes,
yeah,
ma'am.
actually, yeah. Since you pointed out this two dose, even in women or above 15 years, till now, FOGSI or the WHO or the recent things what we have seen have been recommended the three-dose regimen only. So that is what we've been following till now.
Yes, ma'am.
Hmm. But since you
True.
have
True.
pointed out the
Even we
same
also following the same one.
so the sage that since I was not aware of it before, but since you pointed this out, I was just going through the internet for any articles on this, on recommendation of only two-dose regimen, because yes, definitely when we are going for the nanovalent vaccine, the cost is becoming a
Mm.
challenge for us to counsel the women, because some of them would prefer the nanovalent vaccine, which is very expensive. But in the SAGE articles and all, they have said that they have actually started a trial to give the two-dose schedule, but only till 21 years of age. They have not gone beyond that
Yes.
particular age.
Mm.
Basically, we know why we are giving the three-dose after 15 years is because of the immunogenicity. Prior to that 15 years, probably the immunogenicity is good with the two-dose, and they are actually recommending and they're doing a trial on giving this. So we, especially I do not have any experience and have not heard in any conferences or our gynecological conferences about the two-dose regimen for women and children above 15 years of age. So if you have any other articles or you can share anything about this, it would be better for us or later
Yes,
also,
ma'am.
not
Sure.
now.
No, no, there
Currently,
are actually whole comparative studies based on that, but most often centered around the European because
Mhm.
EMA programs. So, depending on those guidelines only, they have changed that their public immunization guidelines to single and dual doses.
Okay.
But
Okay.
they have used quadrivalent, ma'am, not nanovalent. I think
No,
that
no,
I've already
I
mentioned.
understand.
Yeah,
Yeah, yeah, I
yeah.
understand. But what I was thinking, I mean, the similar thing, right? The quadrival, this also has all those four variants, and it has some
Mm.
more in that. But they have actually mentioned that in the Sage article. But I have to go through it. It's just that you pointed out. I just took it out.
Yeah,
So
but guidelines,
probably,
I think it is do 2 and 3 doses only.
yeah, two and three
Correct.
doses. Still now, as per
Yeah.
our FOGSI update and what are all the other oncological bodies have, I mean, the previous things have told us the same thing. So currently we are going on
Mm.
with that only.
So, ma'am, few questions are there in the chat box. So they are asking how effective is a single dose HPV vaccination compared to multi-dose schedules in achieving long-term protection? Can you answer this, ma'am? Mahati, ma'am.
Yes, ma'am. That's what I have just shown you the data. Even the single dose vaccinations, I think the difference was technically in their study, the difference was only 2 to 3%. So how we take it is up to us. But right now, as per the official guidelines, it is 2 doses only. It is not 1 dose. Probably, I think they've just adopted it in their public vaccination programs.
Okay. So another question is like, should AI models be trained on clinical outcomes like say AN3 plus cancer rather than expert labels alone?
I think we have a long way to go there, ma'am. May not be able to actually differentiate CIN2 or 3 by based on AI. I think we have a long way to go there. Yeah.
Okay. Another
Mahati,
question is like, are there
Thing
yeah,
is like they've
ma'am.
actually started this program. Some I think in Silchar or somewhere they are actually pilot of this AI based cervical screening is actually going on, ma'am. We might get a data on depending on that soon.
So, Dr. Mahati, are these available with the AI module when we are doing the VIA? Is it also attached to our mobile phones or like the handheld instrument that we have sometimes, the
Yes, yes,
corpuscular?
ma'am. There is there. The pilots are going on, ma'am.
Okay, but not yet released in the market for
No,
us to
no,
use
no, no, no.
commercially.
Pilots are going on. Yes.
Okay.
Okay. And the question is like, are there scenarios where molecular profiling changes prognosis more significantly than stage alone?
No, 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 ma'am. It is additional to the stage. Obviously, stage trumps over everything.
Okay. Okay, ma'am. Patients undergo upfront germline and somatic testing.
Near 100% of actually by guidelines, all the ovarian cancer patients have to undergo germline testing.
Okay, ma'am.
So what we are now doing is even the
So, any other questions, Neetu?
germline and somatic both are different. Germline we do in blood, somatic we do on the tissue. So ideally, if finances are not an issue, we do both germline and somatic. But if finances are an issue, we actually do germline. If the germline is negative, then we do somatic. But if the germline is positive, that is pretty much good enough, and it means just BRCA positive and will respond very well to PARP inhibitors for us.
Okay. Ma'am, we don't have more questions right now.
Okay. Okay. Mahati ma'am, your take home message.
I think treatment part we are doing a lot and lots of things have come up, but I think our focus should be more on still a good amount of prevention and screening. Yeah, that would be my take home message, ma'am.
Okay. Thank you so much, ma'am, for the elaboration of recent advances on gynecological cancers. So now I can extend my vote of thanks. Anybody have any questions? Please, you can come forward. Okay. Dr. Anita ma'am, shall I go for vote of thanks?
Yes, yes, thank you. And it was really a very
Yeah.
insightful.
On behalf of GOGS ABHYAS team, it is my privilege to propose the vote of thanks for today's meaningful and enlightening webinar held on the occasion of World Cancer Day. And we extend our heartfelt gratitude to our chief guest, Dr. Mala Sibal ma'am, for her inspiring presence and for sharing her vast expertise on insights enriched by her extensive international experience and evidence-based approach have truly elevated today's discussion and greatly benefited all participants. We sincerely thank our guest of honors, Dr. Kandula Ramu sir and Dr. Shrikant sir, for gracing this occasion and for their valuable perspectives, which added immense depth and clinical relevance to the program. And we are thankful to our speaker for delivering an informative and engaging talk on gynecological cancers, current perspectives, and emerging advances, and which was both thought provoking and highly relevant to present day practice. And we also extend our special thanks to moderator Dr. Anita ma'am for steering the discussion effectively and facilitating us meaningful interaction. We acknowledge the efforts of the GOGS team, ABHYAS organizing committee, President Dr. Venkateshwar sir and Secretary Dr. Umashankar sir, who have guided us, and also technical team, Medisage, and all those who are working behind this delivering support. And finally, we thank all the participants for their enthusiastic involvement and active participation, which truly made this webinar impactful. To action, early detection save lives, and informed care changes outcomes. So with this, we conclude today's program. Thank you all and have a wonderful evening. Thank you.
Thank you.
Thank you, Neetu, for this
Thank
opportunity.
you.
Thank you.
Thank you, ma'am. You're always welcome.
Organization. Thank you.
Thank you.
Thank you.